Hi, this is Beverly Hills SMILE Laser Eye Surgeon, Dr. Rajesh Khanna, and I got a special treat for you. An unedited, real-time SMILE laser eye surgery where I'll be highlighting some salient points both for our viewers and the novice SMILE laser eye surgeons. So this is the first step where we have to dock the laser onto the cornea. The learning points here are the centration, because unlike traditional LASIK where we hold the cornea and the eyeball and stabilize it, which causes a lot of pain and redness, here there is no holding, it's just resting on the cornea. So the green flashing light which patient sees has to be centered on the line of sight. Once it is centered, as you saw, we started the suction and now we have good centration. We start the laser like 23 seconds. This is the first pass, which is doing the deeper posterior, and since there's astigmatism, it adds a crescent shape. Now we do the anterior part. You'll see this will extend beyond the posterior cut, and finally the incision being made 4 millimeters at 12 o'clock. Once this is done, we take off the laser part and bring the eye under the microscope, where wow, how clearly can you see? The central white milky is the posterior part of the lenticule, and the periphery is defined by the thinner translucent. Now what I'm doing here is applying a soaked cotton tip. At the site I'm going to be holding the toothed forceps. The reason for that is to stabilize the eye, because this is a very delicate surgery and we don't want the patient to move too fast and rip anything. The first step, identifying the incision with this instrument based on Sinskey hook. Now the very important, this is a key point to make sure we go beyond and above the anterior cut, and that's possible by going to the fringe, coming up on top. We have to make sure we are not in the posterior, and how we are going to do that I'll display in the next step. But we go all the way to the other edge of the incision and then we come out. Now we can begin to see the posterior one through that, but we'll go angle downwards a little bit, and if we were back in the same plane, it'll move freely, our instrument, the Sinskey hook. But here you'll see I'm finding resistance, so that's I'm in the correct plane. The delineation of these two planes is the most critical step for the procedure, especially with lower corrections where it's very thin. If you miss that, then you can be struggling for some time. Once we've done that, we take a spoon-shaped instrument, which will follow the same principle. First go out and above the anterior, and then free the anterior part of the lenticule from the rest of the cornea. There's going to be some resistance, but in anterior you'll find less resistance because there's more space to move around. And we do have to make sure we go all around, nearly 360 degrees, and not to leave any tags in between, because when we take it out, it can cause a hindrance. And also it's important to first make the anterior part totally free, because once we start making the posterior part free, then we have to come to anterior, then the flap can or the disc can start moving, causing confusion. So as you can see, we've gone all around, and there's no harm in making a second pass just to be sure. Now we put some fluid to keep the place wet, the cornea wet. Now we'll go deeper to avoid the anterior opening and go behind the lenticule. There we're gone, and you can see the lenticule starts moving, and we dissect our way till the opposite end, and then we are going to go in both directions, but we have to be careful not to take off totally. In the beginning, we want to leave some anchor. Otherwise, the tissue starts folding on itself and the last part becomes difficult. So we've left some anchor on the right side. Now we are freeing on the left side. And patience is required. And as you can see, patient is very comfortable. They don't feel much. It's done very delicately with slow, measured, thoughtful steps. Once we freed both the upper lamellae and the inferior lamellae, the whole disc will start moving, and then it becomes a little bit more difficult to free the last part. And we do take our techniques from other surgeries like pie surgery, where we do Rex's with the hand all the time. We're going to be using a similar instrument here, device by one of our colleagues and friends, and this is like a remote forceps, which we'll put one edge above the disc and one below to grab it. We need to get a good bite here. If you get a small bite, it can tear off a small piece and then we'll be stuck again. So for the novice surgeons, getting a bigger bite is better than the edge, which can cause again multiple problems. So very carefully we go. Another third point is make sure we don't lift the opening too much, because it can tear the edges of the incision, which can be difficult to seal and can lead to epithelial ingrowth. See, we got the disc, now we are moving it just like a capsular Rex is in presbyopic eye implant surgery. We have to make sure not to scrape the upper part of the remaining cornea. It's done very gently, and we can then delineate where it might be still attached. Here, when we are sitting at 12 o'clock, we can see it's attached to the left side, to the opposite side of the screen. So no problem, we can go back with our spoon, break the remaining attachments. And again, another point for the beginning smile surgeons, a lot of the resistance will depend on how good your laser is working, which again depends on the temperature, humidity. If it's places energy very close to each other, high energy, we'll get smoother cuts. If there is resistance, then we have to use more force. Now in the end, this is a very important point. We open the disc we've taken out to make sure there's no pieces missing, and I use it to squeegee the fluid out from the interface too. And lo and behold, we are done. But I will squeeze out some more with a metal cannula and then dry the wound. Even though it appears that there's a lot of manipulation going on, as you can see, the patient's eye is barely moving. That's because we've numbed the eye and they don't feel anything. All the movements, as I've repeated multiple times, have to be very gentle. No upward force or downward force either, because as I said, if you apply too much upward force, it can tear the edges. Now we are just making sure all the fluid from the interface is out by capillary suction with a Vexel, and the wound is sealed again. And that's it. We are done. We can put some antibiotic steroid drops, and then we'll carefully take out the speculum, and one eye is done already. And the same patient you'll see on a review and a testimonial later on. Thank you. Have a good day. Any questions, whether it be prospective smile patients or beginning smile laser eye surgeons, feel free to contact us. Have a wonderful day.